Welcome to our panel discussion entitled Using a Value-Based Enterprise to Integrate Specialists with Primary Care. Meaningful progress has been made in moving healthcare reimbursement to value-based care, but the documented advances in reducing costs and improving patient outcomes have taken place predominantly in the primary care sector. Significantly less headway has occurred in specialty care. To be sustainable and to be able to move to the next level of cost savings, the value-based initiatives have to connect primary care and specialty care. The distinguished panel today will discuss solutions to further integrating primary care and specialists in value-based care. I think you're going to enjoy the presentation. We're confident we'll be able to provide you with some excellent information. I will be the moderator for the panel. My name is Mike Siegel. I'm a partner in the AmLaw 100 firm of Nelson Mullins, Riley, and Scarborough, and I'm based in the firm's Miami office. I've been a healthcare transactional attorney for 40 years and have been focused on value-based care space for at least 15 years. We have three distinguished and knowledgeable panelists on the program. Actually, we have four. First, we have Bill Nordmark, who is the president and CEO of Enlace Health. Bill is a nationally recognized leader in healthcare technology. Enlace Health is a healthcare software company that is focused on helping the specialty care, primary care data put it together in a meaningful way to accomplish the goals that the panelists will be discussing today. Ed White is my partner at Nelson Mullins. He has nearly 40 years of experience as a healthcare regulatory and transactional attorney. He's written several articles and blogs that discuss value-based care and is particularly focused on the topic of value-based enterprises and how these can help achieve value-based care success. Jonah Brule is a principal and consulting actuary in the healthcare space at the well-known firm of Milliman. He is an expert in Medicare claims data and has worked extensively with clients participating in federally sponsored ACO and bundled care programs, and also with large clinically integrated networks. He's going to bring us his actuarial insight into the use of data with respect to our topic. Kelly Conroy is a principal with Pinnacle, a national healthcare consulting group. She is a leader in the value-based care space, and she's famous for her imaginative ideas and leadership in healthcare delivery. Here's how things are going to proceed. First, Ed is going to explain the concept of a value-based enterprise and its regulatory advantages. Then Jonah will deliver a call to action, discussing the total cost of care with ideas of how to reduce it, creating financial targets, and discussing Medicare payment reforms. Bill will propound a potential solution to further integrating specialists with primary care using a value-based enterprise. Kelly will then provide a perspective from the view of ACO and primary care provider platforms. Finally, if we have some extra time, the panelists will provide us with some closing comments. Let's get started. Okay, Ed, tell us a little bit about value-based enterprises.
Thank you, Mike. I'd like to start with this slide I like to put up when we do these type presentations as we sort of introduce this concept of a value-based enterprise. And it's basically, we're looking at this box in the middle, this rectangular box. And beneath that, we have providers of different types and networks that are affiliated with the arrows, providing services in return for some sort of compensation. And the value-based enterprise, we got the top above that, a box for the healthcare provider that was the creator. It could be any organization, any party. We can assume for purpose of this conversation today, it's an ACO that may have created this to integrate with specialists. You could have investors in a value-based enterprise. But the main point is conceptually, it's a vehicle that can be used to manage care coordination among providers and to contract with payers for value-based payments. We've got the payers up there on the top right of the chart. It can evolve to that point. And when we talk about value-based payments, we're talking about payment systems that are designed to reward providers for hitting quality benchmarks and cost or efficiency benchmarks. And CMS has stated they want the Medicare program in virtually all their payment programs in some type of value-based payment system by 2030. And this is opposed to traditional fee-for-service. But this concept of value-based enterprise emerged from the new Stark and anti-kickback statute regulations that were published a couple of years ago. Now, it's beyond the scope of this topic to do an in-depth discussion of the Stark law, the anti-kickback statute. But just at a very high level, these are two regulatory regimes that are aimed at the federal payment programs. Medicare program is the largest. The Stark law prohibits physicians from making referrals of certain type of services, referred to as designated health services, to entities with which they have a financial relationship, unless an exception applies. So Stark is a law of exceptions. There's very significant penalties that apply if it's violated, including recoupment of any payments made in violation of Stark, anything that was billed to the program. The anti-kickback statute, in contrast, is more fluid and amorphous, and it's basically designed to prevent any type of remuneration or compensation for a party arranging for the referrals or the steering of any kind of business paid by a federal program, principally, again, Medicare. And these concepts, the Stark law and the anti-kickback statute, have been something of a hindrance in the evolution of value-based payments. They tend to be archaic, and they tend to be aimed at the amount of utilization, and they're problematic when you start talking about value-based payment arrangements. And so these new regulations were created to actually accelerate providers' transition from fee-for-service to value-based payments. And if you look at the chart again, the providers below are plugging into the value-based enterprise and its protections through participation agreements, much like an ACO. The value-based enterprise can be overlaid on don't have to be a separate legal entity. We're showing that here. If it's going to be of any magnitude, our recommendation is created as a separate entity, but it could be overlaid on an ACO. It can be created contractually, but it's a conceptual vehicle. The protections are to compensation relationships, with providers. These new rules do not protect ownership interests. You're still under the classic Stark and anti-kickback statute rules with ownership interests. But this is the first time in my career that I've seen CMS, the agency that administers the Stark law, and the OIG, which enforces the anti-kickback statute, collaborate together to create these regulations. And one thing worth mentioning, when you talk about the anti-kickback statute, their regulations create safe harbors. And safe harbors are not mandatory, but they're places where the government has said if you factually fit within a safe harbor, they're not going to bring an enforcement action. And the anti-kickback statute does have criminal sanctions as well. So these two agencies have worked together to create rules that can work in tandem. They're similar, but they are different in some respects. Now, these rules and the protections can apply when parties are working on one of four permitted purposes. And the first is care coordination. The second is improving quality. The third is reducing healthcare costs to payers without reducing quality. And the fourth is transitioning providers from fee-for-service payments to value-based payment arrangements. Now, to structure a value-based enterprise, you have to have at least two or more participants. They have to be working on at least one value-based purpose. That's four we just described. They have to be working on at least one value-based activity. And these activities are not prescribed. You get to create your own protocols and processes and measurements to try to transform care. And the value-based enterprise has to have a governing body. It's responsible for documenting the value-based purposes, documenting the value-based activities, setting the benchmarks, and overseeing the processes and the conduct of the value-based enterprise. You also have to create or define your target patient population. You get to create that. There's no attribution, and like you have in ACOs. And you're basically defining the scope of these protections, so this umbrella of protections from a value-based enterprise, when you define the target patient population that the providers are collaborating to serve and to modify their care. The value-based enterprise, we like to refer to it as the party's own innovation center. There's tremendous flexibility in creating the structures and the models as you go forward. I like to think of these regulations as creating three models. They don't say this specifically, but they're designed this way, both START and anti-kickback. Care coordination is the first, partial risk is the second, and a full risk model the third. I like to think of care coordination as the beginning model where parties are getting started. The anti-kickback statute, safe harbor, allows parties to disproportionately subsidize the startup cost in care coordination, the infrastructure and expenses, and bringing the parties together to function. And that's just unheard of under the classic anti-kickback and START regulations, but you can subsidize up to 85%, one party to the value-based enterprise. The partial risk model is basically, if the providers, if there's the ability to forfeit, a minimum of 10% of their compensation for withholds or failure to hit certain benchmarks, then that qualifies as partial risk, invoking these protections. And that's not much difference than pay for performance programs that are present today in the healthcare industry. And the full risk, your typical global payments and capitation, et cetera, but the protections are the same between partial risk and full risk. So you never really have to migrate or evolve to a full risk organization, even though that will occur to some degree. Now, the key distinctions in these new rules is that they reduce compliance risk. There's generally no fair market value requirement, no prohibition on compensation varying with the volume or value of referrals. And physicians that are in group practices, as defined by START, can be paid directly in relation to their referrals of those services that START generally prohibits the referrals to, these designated health services, when they're functioning in a value-based enterprise and being paid through a value-based enterprise. Again, providers can disproportionately subsidize the infrastructure and startup care coordination costs. These providers in the value-based enterprise can be contractually required to restrict their referrals to other providers in the value-based enterprise. Two exceptions to that are patient choice and medical needs of the patient. And the documentation that goes into creating the value-based activities and the benchmarks and measuring progress overlaps very nicely with clinical integration standards. So you can be simultaneously creating your own SIN as you're managing this value-based enterprise, and which permits contracting with independent parties, with payers within the antitrust standards. So that's an additional benefit. We think perhaps the most important benefit of the value-based enterprise is if it's properly operated, you can create a low-risk regulatory environment apart from these classic rules and these very severe penalties and sanctions that can apply. And to do that, you have to always comply with START, including these new exceptions, the new value-based exceptions. The parties have to be working through the value-based enterprise, and they have to be working to accomplishing a value-based purpose. And if they do that, they're mitigating anti-kickback statute risk, even if they're not directly in safe harbors. And I want to move to this next slide as these other speakers come talk about this model. And this is what we believe a value-based enterprise could be a very good fit for the model you're going to learn and hear about today, to basically allow the collaboration between specialists and primary care providers in a vehicle where there's a low-risk regulatory environment, where the specialists and providers can be communicating and coordinating care, and how each are being paid for that care. That we think this is a wonderful opportunity. So the key takeaway point is that the value-based enterprise, as this evolution of integrating specialists and primary care continues, can be used to change the regulatory landscape, to do some creative, innovative things that our other speakers will be talking about. And Mike, with that, I'll conclude my introduction to the value-based enterprise.
Thank you very much, Ed. Jonah, why don't you now go ahead and describe what financial data tells you about value-based care as an actuary?
Yeah, certainly. So I've entitled this slide, Why Primary Care Physicians and Specialists Need Each Other. I think there is incentive on both sides to enter into these integrated models. ACO models to date have tended towards total cost of care population-based models. Specialist-specific models or episode-based models tend to be more numerous and complex to execute. There's a lot more models you need to cover a similar amount of total cost of care for a population. And so the first round of these models has largely been focused around getting populations covered on a total cost of care basis. In those models, a risk holder needs to be designated as a provider, and primary care physicians are the primary entities that have been designated to hold this total cost of care risk. And so the reason specialists are interested in primary care physicians is the primary care physicians are holding much of this risk as it stands today. And even as we expect models to expand in future, we expect a large proportion of value-based care to still be held in total cost of care population-based models because they cover so much of the healthcare spend. Savings to date in these ACO programs have been driven at least in part by favorable selection, getting the right types of patients covered under this risk, and optimizing risk score coding for these beneficiaries, making sure that the revenue received for these beneficiaries is going to be adequate to generate savings for the ACO. As agreements renew and rebase, however, they get renewed and rebased, budgets get set, and targets get lowered based on recent experience, based on achieved performance. And as that happens, different strategies will be required to maintain savings rates in line with what primary care entity ACOs have been accustomed to. A challenge that primary care physicians face is they only directly manage a relatively small percentage of the patient's total cost of care. As we've described, they could be the right entity to hold that risk, but in order to manage and transform spending for those patients, it is very likely that specialists will need to be engaged and incentivized to take part in that transformation of care. So as we move into the future, we expect that primary care physicians who are leading these ACOs will need to significantly engage with specialists in order to drive the transformation in total cost of care that is likely to be required to continue to generate savings in these models at similar levels to what we've seen thus far. Right now, what we think has occurred is the low-hanging fruit has been picked in these models. And as we move into the later phases of value-based contracting, true transformation of care will be required to generate savings and be expected from the payers if they're going to pay out savings. And specialists certainly seem like they will play a role in there. And what we can see on our next slide is that the percentage of total cost of care that is driven by participants here is the top 20% of patients drive the majority of total cost of care. So when we're talking about transforming care within these models, we're talking largely about impacting the top 20% of most costly patients. And as we can see from this graph, the patient cost moves up quite rapidly as we approach the 80th percentile. Risk scores do not move up that rapidly. What this indicates to me is that solutions that are going to arise within this upper percentile of cost are likely going to be due to truly transforming and managing those costs better, not likely to arise from better coding of risk. We're not going to close that gap with that, and not likely to And we're not likely to transform total population spend without addressing the most expensive beneficiaries that we see here. If we go to my final slide, another thing we see is that of all services that are provided in a total cost of care setting, roughly 80% of them, and number figures here will vary based on which type of population you're looking at, but roughly 80% of all spending is managed or touched by a specialist of some form. So the vast majority of spending that we're actually realizing within a Medicare fee-for-service population, as an example here, is being managed and addressed by specialists. And so if we're going to make changes to that, that will require that we engage specialists and incentivize them to be involved in the transformations of care that we're planning. And so I think as we move forward in these value-based care models, I think the next phase will be truly around how do I change past patterns and past utilization patterns in total cost of care for my attributed lives, and the people that you're going to need to engage with to achieve those goals are going to be specialist physicians.
Well, thank you. That is very illuminating information. Bill, I now would ask you to explain how your company, Enlace, envisions a solution to further integrate specialists with primary care, and why you think it's so important.
Yeah, Mike, thank you. And piggybacking on Jonah's comments, I think this is one of the biggest things that's a passion of ours, is that while the industry is focused so much on primary care, the reality is the cost is not in primary care, as Jonah's slide here is showing. And so the call to action here in the industry is that as Medicare and CMS is making more changes to tighten the belts of the model with the targets and force performance, primarily the V28 is breathing down the necks of all these organizations, you're going to have to see a bending of the cost curve. The only way to bend the cost curve, as the slide shows, is you have to start managing specialty care. And so let's talk about a couple challenges that exist in the industry right now, and why a VBE is so important, and the connectivity between specialists and PCPs is a driving force. So number one, as Jonah outlined, where the costs are is important. Number two, we live in a notionally capitated world. So while all these organizations are technically at risk, they're not technically paying for that risk. And so, you have a PCP that's capitated or has notional risk for a dynamic. They do not have an aligned incentive with specialists that are sitting in a fee-for-service world. So the first issue that the industry has is that misalignment around fee-for-service and specialty, and then in risk arrangements for PCPs. The second issue is that most of these organizations only look at PCP as specialist performance on a specialty alone. You have to look, as Jonah mentioned, on the totality of the performance of the specialist, and you have to look at the ability to manage costs on totality of procedures, et cetera, to find out who are your highest yield specialists and who are your highest performing specialists from a cost and quality perspective. The industry has tried to integrate specialists with e-consults and those types of scenarios. But what we have is a world where primarily, let's say you walk into a PCP's office with knee pain, you're likely getting referred to an orthopod. That orthopod appointment is going to be 7 weeks to see them. And 60% of the people that are in an orthopod's office don't need to be there because they technically don't need surgery. And so you're starting to see these continued challenges in the alignment between PCPs and specialists. You're seeing a little bit better areas of focus here, and for example, the end-stage renal disease and some in nephrology. But the by and large other challenge is who's going to fight for attribution of the patient, right? And so most everybody's attributed to PCPs today. And a lot of the challenge between specialists and PCPs is if I start working with a specialist, am I going to lose the attribution for that patient, which means I lose the attribution of risk. So all of these challenges are underlying themes that are driving issues in the market, and quite frankly, are standing in between a lot of the management and cost dynamics of bending this cost curve, which you're seeing on the slide here. So the power of a value-based enterprise is that it allows specialists and PCPs to enter in arrangements whereby this bending of the cost curve can happen. And as Ed mentioned, the dynamics of what you can do with a VBE drive the value of the connectedness or alignment between a specialist and a PCP. So what is one of the issues that's going to happen in the market? If PCPs don't jump into these arrangements, they're going to be cut out, right? And payers are starting to get very smart about the fact that these specialists will either carve out these arrangements and put specialists in these arrangements, or they're going to put pressure on the PCPs to put or ACOs to put specialists in these arrangements. And there's really 5 items that I'd touch on as key points of where these VBEs drive value. Number 1, the VBE, because of the value-based enterprise, does allow PCPs to steer providers to high-value specialists where these risk arrangements are in place. It also allows you to build the incentive structures that are required so that the specialist is incented to lower the total cost of care and actually participate in savings for the items that Ed mentioned around care coordination and value-based enterprise work. The second thing is that it will incentivize the specialist and PCP to work better in the diagnosis phase. There's so much cost and waste in the diagnosis phase of just the referral patterns and the referral leakage and the different types of costs that go into that handoff, which I mentioned from, say, PCP to orthopod in my example, where the patient is having a horrible experience. If they're not getting the answer they need, they're looking for other answers. Cost is going up and challenges. So the steerage and the care coordination that can happen leveraging the VBE is extremely important. The other dynamic is the VBE incentivizes the specialist to be able to work with a multitude of ACOs and PCPs. So one of the other big challenges in making this valuable for specialists is I may be working with a ACO in my market that has 10,000, 11,000 patients that are attributed to them. In an orthopod's office, that's not a lot of volume. But when you join a VBE and you can aggregate volume, you may in a market work with 3 or 4 or 5 ACOs or PCP organizations to where now I might have 50,000 patients that I'm connected to. That's going to move the needle. So the ability to leverage this VBE, create the CIN or create the types of organizations that are needed is going to aggregate volume to high value specialists where they're incented. Another big dynamic is the risk arrangements that you can put in place. If you think about the dynamic of a fee for service specialist today, they are getting paid for their portion of, let's say, a procedural episode. They are not incented to look at the total cost because they're not in a risk arrangement whereby those PCPs can share that risk with them. And if they lower the total cost, then they are being successful. And that is another key factor in these arrangements. So, Mike, to conclude, the VBE allows the industry or the structure of the VBE, and we in LACE help a lot of these organizations do this, allows the industry to get over a lot of these hurdles, which are keeping the market from adopting these models, whereby the lack of alignment between specialists and PCP from a fee-for-service dynamic, the ability to steer patients and gather volume so you can care about these items are big importance. My call to action would be this ship has sailed. If folks don't get on the boat, V28 is coming. And they need to start bending the cost curve on these items because, as Jonah just mentioned, you are not going to solve these challenges that the industry has on the revenue side or risk adjustment side of the equation anymore. CMS has changed that game, and you're going to have to leverage the VBE to be successful in these specialist programs.
Well, thank you very much, Bill. It's very interesting information, I think, for everybody. Kelly, you have about 8 minutes. Can you please offer us some perspective about all of this?
Sure. Thank you very much for inviting me to this very informative panel. It's really exciting for me to see how far we've come. I started working the first decade of ACOs in 2012, building ACOs back then. And I feel like we spent the first decade just putting the primary care as the quarterback. And now we're trying to spend the second decade figuring out how we can.
Yeah, we worked on that one together, didn't we?
We did work on that one together. It's been a long time, but I'm really excited. And I want to tell you why I'm excited about the second decade, why I think it's an urgency, and why I'm really encouraged that it's actually going to happen because there's a roadmap for it. So the first part about it is I do agree with everybody that's been on the panel. There is an urgency. So if this all just sounds like talk to you, it really is a true urgency. Part B costs are going up. Every ACO knows that. We can see it all across the country, and everybody knows we need to work with the specialists to figure that out. Everybody knows about the 2030 mandate that Ed mentioned, but they're also going to make additional program changes and additional complications to this type of work we're doing, including new quality measures. So it's why it's really important now to get this information and start to really begin to strategize, because we've never had a moment that I can think of where they're going to actually lower the legal regulatory compliance and allow you to innovate, because it's such a big problem. And then the next thing, the reason I really think it's a big urgency is because we all know that 20 or 10,000 baby boomers come into the system a day. In 2024, that's going to be the peak retirement. It's going to go up over 11,000, and it's about 4 million people a year. Total baby boomers of 78 million. So there's no more wiggle room. We got to figure this out, and this is where we're at. So why I'm encouraged is this slide that's on the screen for you right now is the Innovation Center Specialty Strategy Goals. This is focused on their short-term goals. They have not figured out what their long-term goals are. You can see there they expect to have an extended design and implementation period between 2026 and 2030. And so that's where I think is also the perfect time. They're going to allow people and the voices to come back to design something that works right now and try to include all the stakeholders. Further encouraged because they didn't just put this roadmap out there, but they're actually doing this, enhancing specialty care performance data transparency. First thing they said they were going to do is put out shadow bundled data for us. And I'll talk about that in just a second, just to give you a hint about what that is. And then the second thing they're going to do is they're going to come up with specialist performance profiles. So some of you may have heard me speak before. We've always been talking about the PCP having a transcript of excellence about what they do to provide value. Well, the PCP, that's been a little bit more elusive, and there's many programs out there that do sort of profile that, but now the government's going to take all of its data and do that profiling for you to give more transparency to the primary care and where they're sending. And then you can just see the other categories there, 2, 3, and 4. They're already making momentum on this. All the abbreviations are at the bottom, but the oncology model, the guide model, they absolutely have to give a request for information back on these mandatory bundled payment models by 2026. So you can see there is a roadmap, but there's also lots of room for innovation and then to overlay with the VBE. Next slide, just to give you some idea of what they're passing out. They have quarterly shadow bundle data coming from CMS on these particular episodes of care, and you get tons and tons and tons of information. So it's just showing that the government really is they put it out there, and now they are really releasing the information. So I think that's really great. I think we're seeing great examples all over the country. Bill, you mentioned some of them, really great examples. Some of the challenges that I'm seeing across the country is just knowing the roles. There's so many roles with ACOs, APMs, value-based care, ECQMs. I could go on forever, but knowing the rules, knowing when they're going to change, and kind of coming up with your strategy. CMS puts stuff out like this all the time so that you can actually see in the regulations where they're headed. By the time it gets in writing, they've already been thinking about this for 10 years. So knowing the rules, I'm absolutely convinced you cannot make good decisions in an ACO without getting some actuarial help nowadays. They've changed the benchmark so much. If anybody looked at the PCP Flex model, they wrote a new book. I mean, they're just the ACO Reach, they wrote a new book. So like keeping up with all of these rules, really important when you're defining your strategy. Some other challenges, oh, for example, I will say, if you didn't know that version 24 and 20 to 28 was being implemented last year and this year and how it was going to impact your benchmark, big problem, right? If you didn't know that that you would be rebased if you decided to give up on the track you're in now and go into the PCP Flex model, you would get a whole new benchmark, and you may walk into that and not even know, just because there's just so much out there. So I would say surround yourself with people that have been working in this space and can provide you with those answers while you're developing your strategies. A big challenge is integrating the patient engagement. We've been talking about it for 12 years, and it's really not getting there. So hopefully with AI and with the roadmap for specialty care, because it's not going to work if we don't integrate the patient with the doctors. The other challenges I'm seeing are the office functionality. I mean, anybody that brings them a solution, they cannot just disrupt the office workflow. So we have to think about how do we bring these really holistic solutions that are built workflows up from the bottom instead of just saying, here's one more thing you need to do. I'm also seeing vendor overload. People are just absolutely overloaded by all the vendors. Somebody told me yesterday they looked for a healthcare app and it was over 4,000 in the app store. So it's no wonder the patients can't figure out what to do. And then also a big challenge would be silo data. So let me just wrap up a little bit by saying a couple things I would do. I would figure out how to become a top priority for an ACO or an at-risk entity. Ed, I think the VBE is an excellent vehicle, like you said, that could actually be overlaid on top of a currently operating SIN. So if you have one and you know that specialists are not your problem, but your next big thing to tackle, because the low-hanging fruit has been tackled for the last decade, then this is an excellent time. Single sign-on, very important. So many solutions are coming up, and it's just a different workflow. It's a different sign-on. The ACOs, the physicians, just don't want to sign on to one more application. So it's really important. The other thing is, if there's multiple systems, what we find is everybody doesn't speak the same language about attribution. Bill spoke about that a little bit, but how CMS defines attribution and how the different vendors that you work with to help you take care of parts of your population define it can be very different. I have actually seen 4 systems risk stratify populations of people 4 different ways, just because obviously their feeds were different. So that's really important to get that stuff aligned. Also having real-time report cards monitoring the progress. And I think if you can work through some of those challenges, this is the absolute perfect time to use it or dig into what a VBE is and bring your own ideas forward about how to make specialists and VBEs, primary care, work better together.
Well, thank you very much, Kelly.
Thank you.
That actually ends all of our basic speakers, but we have a little time to draw some conclusions. And I think we have about 5 minutes. So I'd like to start out with Jonah, because Jonah, you put all this data together. I'm really impressed with the way you guys do this. And I want to know, do you think the benchmarks will tighten as we move forward, and what's the implications of that?
Yeah, great question. I think it's somewhat clear that benchmarks, as we proceed forward deeper into value-based care, are going to tighten. The main mechanism that we see for that is that benchmarks, as we move forward in agreement periods, get rebased around more recent experience. And more recent experience is better coded, better managed. So we multiply that out over many years. To generate savings on these new tighter benchmarks is going to require ongoing transformation of care, and at some stage being better at transforming care than other entities within the market that are driving that reference trend that you're being held to. So I think it's really important to get a start on transforming care and roadmap towards that if we want to generate similar savings to what we're enjoying right now in the programs.
Well, thanks. That's a very important thing to understand. Kelly, I have been seeing a lot of action, I'm sure you have too, in the Medicare Advantage arena. Plans knocking out areas where they're not going to provide it anymore. a lot of fights between the plans and their providers and the middlemen on this whole thing. And it seems like there's real tightening in the Medicare Advantage market. Can you give just a little bit of an explanation of what's going on there and how that ties into what we're talking about?
Sure, Mike. I think it's exactly the same reason that we're talking about the benchmark that Jonah just mentioned. The Medicare Advantage plans actually are taking a hit with the coding this year. They're taking a hit with their HEDIS measures and their stars. So everything's tightening for them too. So just you can't code your way out of this. You have to actually do the work. And the piece that really does seem to be missing, it's quite obvious if anybody's looking at any of the numbers on a population, is there is just not this alignment with specialists. It's my husband's a big football fan, and I try to explain it to him. It's like we made the PCP a quarterback, but we didn't give him the playbook to throw it to anybody to make sure that the patient was going to get across the goal line safe and healthy and protected with access and preventative care and got their medications and their refills. So I think it's the same reason, Mike, is everything is just getting tighter, and the real hard work, which is getting the patients and the doctors and the primaries all talking and communicating back and forth, and then add the complication. I don't know if it's a complication or it's going to be wonderful for us, but artificial intelligence, hopefully that can make some of this other dysfunction that we have in offices easier for them so that they can really provide population health. That would be my thought on it, Mike.
So you would say that when we did the original ACOs and they rolled up their sleeves to try to find savings, which was there. I mean, we could see from what happened with Medicare Advantage that there was savings available and people eventually got it. But you're telling me now you really have to roll up your sleeves even tighter and dig into these numbers to get advanced situations.
I think so. Jonah could speak to it better, but I do think that we've made significant progress in at least looking at our patients as a population of people that we want to help, not just those who show up for us at the visit, but all those ones we're worried about that didn't show up for the visit. So we did do all the right things in that first decade, but the benchmark is shrinking. So this is where getting the specialists and the primaries to transform the way medicine is dealt. This is where the real hard work comes in now. Jonah, did you want to weigh in on that?
Yeah, certainly. I just layer in that we would naturally expect in models that are going to pay us for savings that we have to continue to generate new ways to save money in the programs in order to share in those savings. And so I think as we progress forward down this track, there will probably be transformations of care that haven't yet seriously been considered or seen to date in these programs.
And if you wouldn't mind if I could just add, CMS really is spreading this out all over all kinds of different programs. So there's just, like he said, there's going to be so many programs, and it's really going to come down to who can find the most efficient, automated way to get this transformation to happen with the specialists. And none of that's going to happen until we align incentives. So this is why we're encouraged that they're doing so much work to align incentives for the specialists. Just asking the specialists, I think you mentioned this, Bill, or it was in the blog, for a 5 to 10% discount off their fee for service, it's not going to work. It's just going to lead to a dead end. They don't want to do it. And I don't know, the new physician fee schedule just came out, and boy, everybody's getting a hit on their fee for service schedule. So this real hard work needed to start many years ago, but if you haven't started, 2026 to 2030, you really need to be thinking about your care or your journey on a value-based care.
We're just about out of time, but first of all, I want everybody to notice the PowerPoint piece that's on the screen, which is basically a whole structure that we set up about how value-based enterprises work, and you might want to take a look at that. And Bill and Ed, if you have a few very, very short comments about all of this, I would appreciate it.
Bill, you go first.
Yeah, I would just say that the model is backwards. And to use the football analogy, we made the quarterback this PCP, but they don't actually control any of the players on the field. And it's like they're not even playing the game. And one of the biggest challenges the market has is nobody has to go to their PCP to get service from a specialist. So they can't really control the cost. the overwhelming majority of the cost savings that have been realized to date has been avoidance of service, avoiding inpatient utilization, avoiding services, kind of closing some care gaps, but we never truly bent the cost curve on how healthcare is paid for. And that's what the VBE can enable, and it can enable the specialists to play a key role in bending that cost curve and realigning incentives with the PCP partnership. I think that's the biggest thing that this can do.
And you got a minute.
And I would add to that, this value-based enterprise creates a low-risk environment. So when you've got specialists and primary care working together and they're pushing patients from one to the other and keeping diagnosis with the primary care and directing referrals to certain specialists, you're in a lower risk regulatory environment. And if you want more detail about this model and the discussion, we do have a blog that we provided that you can get with the materials with this webinar as well, that goes into more details on this conversation as well.
Well, I want to thank everybody for participating on our panel, and I want to thank everybody who's been watching this. And I hope that we gave you some useful information that will help you. We have emphasized the urgency of all of this, so I'm going to say it one more time. We're in the middle of a transformation, and it's urgent that you focus on it now. Thank you very much, and have a great day.
Thank you.